Hello everyone, welcome to this Informed CE Masterclass where we are aimed at eliminating redundancy in drug information to really drive home evidence-based care. My name is Scott Perkins and I'm going to be your presenter for today's CE. If you haven't been a part of one of our CEs before, let me briefly explain how this works. Informed has a database of over 10,000 drug information questions that we've been asked over the past several years. And we found that if a healthcare provider has a clinical question, that there's actually about a 40% chance or so that another provider out there somewhere has had a similar request or inquiry. And so part of this CE process is to really try to get ahead of the curve and answer questions that folks might have before they even ask them or send them our way. So we look for these questions that have been commonly asked or are high value questions to provide these CE topics so that you can be informed on some of the most important clinical inquiries that we get. Now, in saying that, if you have a topic or suggestion or any sort of clinical question that you would like for us to develop a CE around, I encourage you to please reach out to Janvi, that's JANHAVI, at informed.com, and we'll try our best to develop a CE around that topic for you. Today's topic is Inclisiran and hyperlipidemia, a data analysis perspective. This presentation was developed by Janvi Punyarthi, who is the Director of Brand Development at Informed. As I mentioned earlier, my name is Scott Perkins, and I will be delivering the CE today. I'm a co-director of drug information at Campbell University, where I also act as a clinical associate professor. And I've been an academic partner at Informed for the past several years as well. Neither myself nor Dr. Punyarthi have any relevant financial relationships that we need to disclose. Today's learning objectives are: upon successful completion of this knowledge-based course, pharmacists should be able to compare and contrast Inclisiran's LDL cholesterol-lowering mechanism from traditional therapies, outline the safety profile and trial data for Inclisiran, define the patient population benefiting most from Inclisiran, summarize the advantages and the disadvantages for outcomes as well as adherence for patients taking Inclisiran, and finally, our last objective is to discuss practical considerations for Inclisiran dosing, administration, and patient monitoring in the clinical practice. Inclisiran is a lipid-lowering medication that was approved in 2021 by the United States Food and Drug Administration. So Inclisiran is an anti-lipemic, small interfering ribonucleic acid agent. You'll often see this as denoted as siRNA. Now, the indication for Inclisiran recently changed. It was recently approved by the FDA to modify the language that was utilized in the indication section of this product's product labeling. So it currently reads that it should be used as an adjunct to diet and statin therapy for the treatment of adults with primary hyperlipidemia, including heterozygous familial hypercholesterolemia, to reduce low-density lipoprotein cholesterol, or LDL-C. I do think that it's important to note the previous indication did have some caveats. And so it's important to note that the previous indication specifically indicated that this was to be used in adults with heterozygous familial hypercholesterolemia or clinical atherosclerotic cardiovascular disease, or ASCVD. And the left out language that we currently have specifically tying it to primary hyperlipidemia. And importantly, the previous language also utilized a section that was termed limitations of use. And this limitations of use section in the indication section stated that the effect of this agent on cardiovascular morbidity and mortality has not been determined. So that language has been removed, as you can see from the current indications. However, it's important to note, and we'll discuss this throughout the presentation, that the evidence to support utilizing this agent for morbidity and mortality has still not been determined. So even though that statement has been removed from the indication, we still don't have cardiovascular data for this agent. So we're going to be waiting until 2026 or 2027 for those data. But in the meantime, that information has been removed from the indication section. The dose for Inclisiran is 284 milligrams, and it's delivered in a 1.5 milliliter dose, and it is injected subcutaneously in a single dose pre-filled syringe. In terms of the route of administration, the 284 milligrams is delivered subcutaneously initially, and then again at 3 months, and then after that, it's administered every 6 months. If a planned dose is missed by less than 3 months, then we can administer Inclisiran and maintain the dosing according to the patient's original schedule. If a planned dose is missed by more than those 3 months, then we do want to restart with the initial dosing schedule. So this does give us a fairly significant leeway if a patient does miss by just a couple of days or even a month or so, which is nice in terms of adherence and staying on schedule. This is a medication that needs to be stored at room temperature with excursions allowed from 15 and 30 degrees Celsius. So briefly, heterozygous familial hypercholesterolemia. This is a common yet underdiagnosed autosomal dominant disorder. It's kind of characterized by a lifelong elevation of our LDL. So you'll often see very high LDL numbers in these individuals. So if it's left untreated, complications, as you can imagine, may lead to early onset atherosclerosis and, of course, an increased risk for cardiovascular events. And this was the initial approval for this agent, which has now been expanded to primary hyperlipidemia. So we're moving closer to a similar statin-based use for this agent, similar to some of our other PCSK9 inhibitor or focused agents. Inclisiran is a double-stranded small interfering ribonucleic acid, or siRNA, as I mentioned earlier, conjugated on the sense strand with tri-antennary N-acetylgalactosamine to facilitate the uptake by hepatocytes. In these hepatocyte, in our hepatic cells, Inclisiran utilizes the RNA interference mechanism and directs catalytic breakdown of mRNA for PCSK9, and thereby increasing the LDL cholesterol receptor recycling and expression on the hepatic cell surface. This increases the LDL-C uptake and ultimately lowers our LDL cholesterol levels that we have in circulation. In terms of the pharmacodynamics of this agent, remember, we give this agent subcutaneously. We're giving 284 milligrams sub-Q in 1.5 milliliters. We'll actually notice a reduction in our low-density lipoprotein cholesterol as early as 14 days after our initial dose. But the extent to which we see reductions in LDL can range anywhere from about a third to about 50% reduction in LDL. And this can be observed anywhere between that first 30 to 180 days. So a month to about 6 months, we're typically going to see our max effect. And that max effect could reach approximately 50 to a little more than 50%. Now, following a dose, day 1 and day 90 of 284 milligrams of inclisiran, the mean serum PCSK9 levels were reduced by approximately 75% and 69% at day 120 and day 180, respectively. In clinical studies, following 4 separate doses at day 1, at 3 months, around 9 months, and then about 15 months, LDL-C, total cholesterol, ApoB, and non-HDL cholesterol were all reduced. Looking at our ADME, after administration of our approved dose of 284 milligrams, the apparent volume of distribution is approximately 500 liters. Inclisiran is 87% protein bound and has high uptake and selectivity for the liver, which is where its primary mechanism of action is. Inclisiran is primarily metabolized by nucleases to shorter nucleotides of varying lengths. Importantly, inclisiran is not a substrate for CYP450 or other transporters. The half-life for inclisiran is approximately 9 hours, and no accumulation occurs with multiple dosing. Approximately 16% of inclisiran is cleared through the kidney. In our 2018 American College of Cardiology and American Heart Association guidelines, lipid-lowering therapies are recommended for patients at baseline LDL-C of greater than 190 milligrams per deciliter. These guidelines recommend that patients aged 30 to 75 years with heterozygous familial hypercholesterolemia and an LDL-C level of 100 milligrams per deciliter or more who are on a maximally tolerated statin and ezetimibe therapy, that the addition of a PCSK9 inhibitor may be considered. Given that many patients with familial hypercholesterolemia will have documented coronary artery disease and will continue to be at very high risk for future atherosclerotic cardiovascular disease, it is suggested to use an LDL-C threshold of 70 milligrams per deciliter for the addition of non-statins to statin therapy. Non-statins include ezetimibe, bile acid sequestrants, as well as our PCSK9 inhibitors. At the time of publication, inclisiran, a long-acting synthetic small interferon ribonucleic acid, or siRNA molecule, used to target hepatic production of PCSK9 and reduce LDL-C, was considered experimental as it was undergoing analysis in our phase 2 trial, the Orion 1 trial. It's important to note that since these guidelines were published, we started to gather more information on reduced cardiovascular outcomes with some of our other PCSK9 inhibitors. And so other opinions and guidance on this topic do include the use of those agents as recommended therapies after statin use. Of course, it's very important to consider the adverse effects and the safety of our agent, inclisiran. In terms of dermatologic side effects, as you might expect, injection site reactions are the most common here at about 8.2%. Diarrhea is likely to happen in about 4% of the patients taking inclisiran. Urinary tract infections can occur in about the same amount of patients, about 4.4%. We also see some neuromuscular and skeletal adverse effects, including arthralgia and pain in the extremities at about 3 to 5%. Inclisiran may also have some bronchitis and dyspnea associated with it. Again, both of these occur in less than 5% of the patients. Other safety considerations and use in special populations to consider when utilizing inclisiran are that there's no contraindications for this agent at this time. There are no box warnings. Uh, it's important to note that in terms of pregnancy, that we should discontinue inclisiran when pregnancy is considered. Inclisiran may cause fetal harm when administered to pregnant patients based on the mechanism of action. There are no available data in pregnant patients to evaluate for a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes. We also don't have any information on the presence of inclisiran in human breast milk, breastfed infants, or just generally its effects on milk production. We did see in animal studies that inclisiran was present in the milk of lactating rats and all dose groups that were studied. Given the poor bioavailability of these products, it's considered unlikely that low levels of inclisiran present in milk will adversely impact an infant's development during lactation. And so it's ultimately important to weigh the risks and benefits of utilizing this in a breastfeeding mother. The immunogenicity of inclisiran has been evaluated using screening and confirmatory immunoassays for the detection of binding anti-drug antibodies to inclisiran. In placebo-controlled clinical trials, 1,830 patients had samples tested for anti-drug antibodies. These were confirmed to be positive in about 33 patients, or 1.8% of the patients, prior to dosing, and in 90 or 4.9% of patients during the 18 months of treatment with inclisiran. About 31 or 1.7% of inclisiran treated patients had a negative sample at baseline and had a persistent anti-drug antibody response, defined as 2 confirmed positive samples separated by at least 16 weeks or a single confirmed positive final sample. There was no evidence that the presence of anti-drug binding antibodies impacted the pharmacodynamic profile, clinical response, or safety of inclisiran, but the long-term consequences of continuing inclisiran treatment in the presence of anti-drug binding antibodies are unknown. So inclisiran is a first in its class of siRNA agents, but it is similar and works similar to our PCSK9 inhibitor monoclonal antibody agents. But let's take a brief look at how these two agents differ, because there are some important differences. There are some potential benefits and some drawbacks to the use of inclisiran that we want to discuss. So let's briefly look at some of the data, some of the information around this drug and its comparators. Inclisiran is our siRNA agent, and it differs from our other PCSK9 like alirocumab and evolocumab. Both do have an effect on PCSK9. Inclisiran ultimately inhibits PCSK9 production, whereas our monoclonal antibodies inhibit PCSK9's ability to bind to our LDL receptors and thereby causing them to degrade. As a result, inclisiran ultimately works intracellularly, and the monoclonal antibodies actually work extracellularly. So inclisiran will actually decrease our total PCSK9 levels, whereas our monoclonal antibodies will actually increase our plasma levels of PCSK9. The amount of plasma-free PCSK9 levels will be decreased by both of these agents, however. The expected reduction in low-density lipoprotein cholesterol with inclisiran is around 50%. And again, you really get to that number within 1 to 6 months of use, whereas our monoclonal antibodies generally have a little bit of a higher expected reduction in LDL of about 50 to 60% reduction. The expected amount of lipoprotein A reduction with inclisiran is 17 to 25%, whereas with our monoclonal antibodies, that is also a greater reduction of 25 to 30%. While both of these agents are injected subcutaneously, Inclisiran must be administered by a healthcare provider in a clinic, whereas our monoclonal antibodies can be given by the patient at home. And speaking of administration, the frequency at which both of these categories of drugs are given also differ significantly. Inclisiran is delivered on day 1, day 90, or at 3 months, and then every 6 months thereafter. So we're delivering this 1 or 2 times every year. Whereas our monoclonal antibodies are given standard every 2 to 4 weeks, so once or twice a month. So there is a potential benefit here to the use of inclisiran in those who may not be able to adhere to the once or twice a month administration frequency. The injection volume is fairly similar. It's about 1.5 milliliters for inclisiran and either 1 milliliter or about 3 milliliters for our monoclonal antibodies. The administration times actually for our monoclonal antibodies are actually going to be dependent on the volume of drug that we're actually giving these patients. So it may be delivered over 8 to 10 seconds at a smaller dose and up to 9 minutes in our larger doses. Storage requirements also differ amongst these agents. Inclisiran should not be frozen, whereas our monoclonal antibodies should be refrigerated. They're stable at room temperature for up to 30 days, and they should also not be frozen. The most common side effects for inclisiran, as we mentioned earlier, are injection site reactions, and these range from about 2.6% to 17%. Whereas in our monoclonal antibodies, these, while they're still the most common adverse event, they occur less frequently at 2.1 to 3.8%. And here is one of our most important factors that we need to consider when we're choosing between these types of non-statin agents, these PCSK9 agents. Our MACE outcomes, our major adverse cardiovascular event reduction outcomes. Inclisiran currently does not have any data to support reduction in our MACE outcomes, though the data on that is expected to be published in 2026 or 2027. Again, we don't know what those data are. We don't know what kind of reduction we might see with inclisiran, and we still have to wait several more years to get that data. However, with our monoclonal antibodies, we do currently have MACE reduction data that's currently published and provides a major reason to prefer our monoclonal antibodies over inclisiran because our outcome studies clearly are highly beneficial in directing therapy in an appropriate fashion. We don't have any mortality reduction data with inclisiran, but again, we have mortality reduction data with our monoclonal antibodies. Annual drug costs, if we really look at this and kind of tease it out, are going to be roughly the same. Inclisiran is $8,000 per year, whereas our monoclonal antibodies are roughly $7,200 per year. We'll go ahead and bring up our calculator here and we'll calculate this out. So inclisiran is available in a 1.5 milliliter vial that costs $2,665 for 1.5 milliliters. So if we multiply that by 1.5, it's about $4,000 per dose. Since this is given twice a year, it's going to equal about $8,000 over the course of 12 months. If we look at our monoclonal antibodies, these are typically given about $300 per milliliter. And this can be given every 2 weeks. So this can be up to $600 per month if we're giving it 2 times a month. And of course, over 12 months, that means we're paying $7,200. So they're roughly the same in terms of cost. So now let's take a moment to really dive deep into the data that we do have on this agent and try to figure out what patients would benefit from the use of inclisiran What are some of the drawbacks? And what type of information do we have to support the use in patients with hyperlipidemia? We're going to look at several trials here. Trial 1 is a highly durable RNA therapeutic inhibitor of PCSK9. This was published by Fitzgerald and colleagues. It was a phase 1 randomized single-blind placebo-controlled study, and it recruited both men and women between the ages of 18 to 60 years in the single-dose phase and 18 to 75 years of age in the multi-dose phase, who had a serum low-density lipoprotein cholesterol, or an LDL-C, of at least 100 milligrams per deciliter and a fasting triglyceride level of less than 400 milligrams per deciliter. There were two phases of this study. There was a single ascending dose phase of Inclisiran and a multiple ascending dose phase of Inclisiran. In the single ascending dose phase, patients were given this single ascending dose or placebo, and they were given this at doses of 25, 100, 300, 500, or 800 milligrams. In the multiple ascending dose phase of Inclisiran or placebo, patients were given 100 milligrams weekly for 4 doses, 250 milligrams every other week for 2 doses, or 300 or 500 milligrams monthly for 2 doses. And they were given this with or without concurrent statin therapy. In the single dose phase, there was a reduction of LDL up to 50.6% from baseline with the Inclisiran doses of 100 milligrams or more. Also, there was a reduction in our PCSK9 level up to 74.5% from baseline with Inclisiran doses of 300 milligrams or more. These reductions that they saw were actually maintained at day 180 for doses 300 milligrams or more. In the multiple dose phase, there was a reduction of LDL up to 59.7% from baseline to day 84. There was also a reduction in PCSK9 level up to 83.8% from baseline. In this study, there were no reports of serious adverse events. In our second trial, the Orion-1 study, this was Inclisiran in patients at high cardiovascular risk with elevated LDL cholesterol. Orion-1 was a phase 2 multi-center double-blind placebo-controlled study. It included more patients than our previous study. We included 500 men and women. These individuals needed to be 18 years of age or older with an LDL level at screening higher than 70 milligrams per deciliter for patients with a history of atherosclerotic cardiovascular events, or higher than 100 milligrams per deciliter for our patients without a history of ASCVD. Patients were given either placebo or one dose of 200, 300, or 500 milligrams of Inclisiran on day 1, or 2 doses of 100, 200, 300 milligrams of Inclisiran on days 1 and day 90. At 6 months, the mean reductions in LDL levels were 27.9% and ranged to 41.9% after a single dose of Inclisiran, and 35.5% to 52.6% after 2 doses of Inclisiran. And this was noted to be statistically significant. In fact, 48% of the patients who received the regimen had an LDL level below 50 milligrams per deciliter at 6 months. At day 240, PCSK9 and LDL-C levels remained significantly lower than at baseline in association with Inclisiran regimens. Serious adverse events occurred in 11% of the patients who received Inclisiran and in 8% of the patients who received placebo. Our third trial is the effect of 1 or 2 doses of Inclisiran on low-density lipoprotein cholesterol levels. This is the Orion-1 one-year follow-up study. A phase 2 multi-center double-blind placebo-controlled study. The participants included were mentioned earlier. And the intervention in the follow-up study was the same as I previously mentioned in the original study. In terms of results for our Orion 1 one-year follow-up study, it was noted that 1 dose of Inclisiran on day 1 and 2 doses of Inclisiran on days 1 and 90 lowered time average LDL levels over 1 year by 29.5% to 38.7% and by 29.9% to 46.4% respectively in a dose-dependent manner. On average, patients actually maintained an LDL reduction of 50% for at least 6 months after 2 doses of 300 milligrams of Inclisiran on days 1 and 90, producing the greatest mean reduction in LDL over 1 year. Our fourth trial is a long-term Inclisiran in subjects with high cardiovascular risk and elevated LDL. This was the Orion 3 study, and it was a phase 2 open-label long-term extension study of the Orion 1 study. There were 490 participants who completed the Orion 1 study and were previously treated with any dose of Inclisiran. Patients were treated with 300 milligrams of Inclisiran sodium twice per year, and this included 290 patients, or 140 milligrams of evolocumab every 2 weeks for 1 year, followed by 300 milligrams of Inclisiran sodium on day 360, day 450, and every 6 months after that. This included a total of 92 patients in that group. At day 210 of the Orion 3 trial, LDL was reduced by a mean of 51%, and PCSK9 levels were decreased by a mean of 77%. A consistent long-term effect of the 300 milligram dose of Inclisiran on LDL was observed in the Orion 3 trial over about 22 months, and the time averaged lowering of LDL was approximately 60 milligrams per deciliter. During at least 3 years of follow-up, there were no changes in the overall safety profile and no laboratory test abnormalities associated with the treatment. The fifth publication we'll discuss was published in the New England Journal of Medicine in 2022, and it's titled 2 Phase 3 Trials of Inclisiran in Patients with Elevated LDL Cholesterol. This is our first Phase 3 study we'll discuss. The trial also goes by the name of the Orion 10 trial. Again, it's a Phase 3 randomized, double-blind, placebo-controlled parallel group study. It included 1,561 adults in the United States with atherosclerotic cardiovascular disease and LDL levels at screening of 70 milligrams per deciliter or higher. Patients in this Phase 3 trial were randomly assigned in a 1-to-1 ratio to receive either Inclisiran at the currently approved 284 milligram dose or placebo. These were administered by subcutaneous injection on day 1, day 90, and every 6 months thereafter over a period of 540 days. This approach to administration does reflect the current administration approved by the FDA. On day 510, Inclisiran reduced LDL levels by 52.3% with corresponding time-adjusted reductions of 53.8%. That was statistically significant for all comparisons versus placebo. Adverse events were generally similar in the Inclisiran and placebo groups, although injection site adverse events were more frequent with Inclisiran than with placebo. The adverse effects occurred at rates of 2.6% in the Inclisiran group and 0.9% in the placebo group. The data for our next study was also published alongside Orion 10 in the New England Journal of Medicine's publication. Again, the title of the publication was the 2 Phase 3 Trials of Inclisiran in Patients with Elevated LDL Cholesterol. And this study went by the name Orion 11. It was also a Phase 3 randomized, double-blind, placebo-controlled parallel group study. 1,617 adults in Europe and South Africa were included in this study. These individuals needed to have atherosclerotic cardiovascular disease itself with an LDL of 70 or higher, or an atherosclerotic cardiovascular disease risk equivalent and an LDL of 100 milligrams per deciliter or higher. These individuals were randomly assigned in a 1-to-1 ratio to receive either Inclisiran at 284 milligrams or placebo. These agents were administered subcutaneously on days 1, 90, and every 6 months thereafter over a period of 540 days. So again, the frequency of administration reflects what is currently approved by the FDA. At day 510, Inclisiran reduced LDL cholesterol levels by 49.9% with corresponding time-adjusted reductions of 49.2%. And again, these were all considered to be statistically significant when compared to placebo. Adverse events were generally similar in the Inclisiran and placebo groups, although injection site adverse events were more frequent with Inclisiran than with placebo at rates of 4.7 and 0.5% respectively. The second trial we'll look at is Inclisiran for the treatment of heterozygous familial hypercholesterolemia. This was the Orion 9 trial, and it was a phase 3 double-blind randomized placebo-controlled study, which included 482 adults with a diagnosis of heterozygous familial hypercholesterolemia with an LDL of at least 100 milligrams per deciliter, despite receiving a maximally accepted dose of statin therapy with or without ezetimibe. Patients were assigned 1-to-1 to receive Inclisiran at doses of 300 milligrams or matching placebo. These were administered at 1.5 milliliters as a subcutaneous injection on days 1, 90, 270, and 450. At day 510, the percentage change in the LDL cholesterol level was a reduction of 39.7% in the Inclisiran group and an increase of 8.2% in the placebo group for a between-group difference of negative 47.9 percentage points. The adverse events and serious adverse events were similar between both of these two groups. It's very important to note that there are some ongoing studies, Orion 5, 4, and the Victorian 2P study. It's critical to note that these studies that are being published, the Orion 4 and the Victorian 2P studies specifically, are our outcomes-focused studies. So the Orion 4 study is including 1,500 participants, 55 years or older, with pre-existing ASCVD, and we're specifically going to be looking at some of our MACE outcomes and the impact of Inclisiran on those. Now, for Orion 4, we don't expect to have any sort of data until 2026. For the Victorian 2P study, we're actually going to have to wait a whole another year to 2027 to get any kind of MACE outcomes for those individuals. The Victorian 2P study actually includes 15,000 participants who are 40 years or older with a fasting LDL greater than or equal to 70 milligrams per deciliter and an established cardiovascular disease who are on a stable and well-tolerated lipid-lowering regimen that must include a high-intensity statin therapy. So it'll be interesting to see what the results are for those ongoing studies, and they will be critical to the clinical use of Inclisiran in the future. But we won't have certainty about a really important topic like MACE outcomes and cardiovascular risk until about 3 years from now, really. So it's critical to know that when we're trying to figure out the place in therapy for Inclisiran. Let's now take a brief moment to review the agent, figure out where it might fit into therapy, and look at some of the advantages and disadvantages of Inclisiran. The data that we do have about this agent does clearly indicate that it can be utilized as an adjunct to diet and statin therapy for the treatment of adults with primary hyperlipidemia, including heterozygous familial hypercholesterolemia, to reduce low-density lipoprotein cholesterol. So it can effectively be utilized as it's indicated. The efficacy of Inclisiran was well documented in 3 phase 3 randomized, double-blind, placebo-controlled trials, showed a significant reduction in LDL cholesterol by approximately 50%. The use of Inclisiran was also associated with consistent improvements in other lipid panel parameters, including total cholesterol, non-HDL cholesterol, apolipoprotein B, and triglycerides compared to placebo at all time points. The total number of non-adjudicated cardiovascular events observed in current phase 3 trials was too small to draw meaningful conclusions about any potential benefits of Inclisiran on cardiovascular outcomes. Cardiovascular studies, as I mentioned, are ongoing. It does appear to be a safe medication. Common adverse effects occur in greater than or equal to 3% of patients, the most frequent being the injection site reactions, but also arthralgia, urinary tract infections, diarrhea, bronchitis, pain in the extremities, and dyspnea. The majority of our injection site reactions were graded as mild, and none were described as severe or persistent. The longer-term safety profiles are currently under investigation in our ongoing open-label trials. In terms of the advantages versus the disadvantages of using Inclisiran, there are some advantages, but there's one clear disadvantage that is going to preclude the use of this agent in the majority of patients. The major advantage to Inclisiran is the frequency of administration. With an administration of every 6 months versus 2 to 4 weeks, there's a clear potential benefit to medication adherence with Inclisiran versus our monoclonal antibody agents that target PCSK9. It's also important to note that this medication does not require self-administration, but it does require patients to come into the clinic. It does have good tolerability, similar to our other PCSK9 inhibitors, and it does have a favorable safety profile, again, similar to our PCSK9 inhibitors, and actually perhaps a little worse than those agents. In terms of the disadvantages, the major disadvantage with Inclisiran is that we currently don't have cardiovascular outcomes data. Doesn't mean that it doesn't affect cardiovascular outcomes. We just don't have the data yet to be able to determine whether or not it does or doesn't. We won't have that for about another 3 to 4 years. While the cost difference isn't that much, it's not extremely more expensive on an annual basis. Our PCSK9 therapies are costly, and we're spending about $4,000 every 6 months for these agents. And so if we don't have some insurance help, it will be difficult to get a lot of patients on these agents. So who might ultimately benefit? Well, with the new changes in indication, this can be given to patients with primary hyperlipidemia, but it needs to be individuals who need additional lipid lowering. So at this time, our other PCSK9 therapies are preferred because they do have cardiovascular outcomes benefits. Now, Inclisiran could be used as an alternative to those agents in a small population of patients who may not tolerate other PCSK9 therapies, or those who may be unwilling to self-inject. And of course, the most important is the population of patients who are non-adherent to the 2 to 4 week dosing schedule for those other PCSK9 agents. The 6-month dosing frequency for Inclisiran does provide a benefit. So let's now take a look and review a couple of wrap-up questions before we close things out for the CE. So our first question is, select the correct statement regarding Inclisiran's mechanism of action. Is it a novel siRNA drug that reduces PCSK9 production through a gene silencing mechanism? It is a novel PCSK9 inhibitor that reduces LDL production through a metabolic mechanism? Is it a novel siRNA drug that increases PCSK9 production through a gene silencing mechanism? Is it a novel PCSK9 inhibitor drug that increases LDL production through a metabolic mechanism? And the answer is C. So it reduces PCSK9 production through a gene silencing mechanism. What is the most common adverse effect associated with Inclisiran? Nausea, injection site reaction, urinary tract infection, or bronchitis? While all of these can technically occur, the most common adverse effect is injection site reaction. All right, what changes were recently made to Inclisiran's approved indications? Is that patients must now be on a maximally tolerated statin? Patients must now be statin therapy naive? Is it that we can now prescribe Inclisiran for primary hyperlipidemia? Is it now only indicated for heterozygous familial hypercholesterolemia? And the answer is C. It can be prescribed for primary hyperlipidemia now. Fill in the blank. Administer Inclisiran 284 milligrams as a single subcutaneous injection initially, and again at how many months? And then again at how many months after that? Is it 3 to 6 months for the second and the third injection? Is it 3 and 3 months, 1 and 3 months, or 3 months for the second and then another month for the third injection? The correct answer is A. It's administered initially and then 3 months after that, and then another 3 months, and then 6 months afterwards. And finally, our fifth question is, the data indicates that Inclisiran showed improvements in what levels? Is it total cholesterol, non-HDL cholesterol, or apolipoprotein B? Or is it D, all of the above? And the correct answer is D, all of the above. So that's all for today's continuing education program. I appreciate you all joining me today, and I wish you the best.